morning, good afternoon, and good evening, everyone. I hope everyone joining us is coming from better weather than what we've been experiencing over the past few days in Toronto, which has been lots of rain. But welcome to another week of Global Café. My name is Roxana, and today I'm very excited to be introducing you all to Professor Jolene Skordis for the topic of health equity among older adults. Now, to help set the discussion as a little bit of a background on Jolene, she is a professor of economics specializing in health and development. Jolene is Vice Dean for the University College London's Faculty of Population Health Sciences, Head of the Department of Environment and Community Health, Chair of the European Global Health Research Institute Network, a Senior Research Fellow at the Institute for the Future of Work, and a Fellow for the Royal Society for Public Health. She is a regular advisor to the WHO, World Bank, and the Global Fund as well. Jolene works primarily within randomized trials of complex public health interventions with research programs spanning fiscal space for sustainable and scalable health service delivery, anti-poverty programs, gender empowerment, social network to support behavior change, and the promotion of health equity. Her work has directly influenced government policy in a range of countries as well. So, it really goes without saying that your schedule is very busy, Jolene. So thank you very much for your time today. And we're looking forward to spending the next hour or so together. But Jolene, perhaps to start things off, I'll just hand the floor over to you. Can you actually tell us a little about yourself? With your incredible, achievements, can you walk us through your journey, both from a professional standpoint, but also personally, of how, you are where you are today?
Thank you so much, and thank you for the invitation to speak here today. I'm really enjoying speaking more about the work that we're doing on aging and on healthy aging, because actually my career started on the other end of the life trajectory. I started working in the HIV pandemic in Southern Africa. I worked on prevention of mother-to-child transmission of HIV, moved from that into child survival, and really spent many years working on the survival initiative, moved from surviving to thriving. And then from thriving, it was a natural segue into thriving across the life course. So it's been a really fascinating journey. And it feels a natural next step that our work, my work, and that of my really excellent team has segued into work now on aging populations, as not only do high income countries face the challenges and opportunities that an aging population offers, but also low and middle income countries, which are very populous, face many of the same challenges. So it's really exciting to be here, and thank you very much. I realize my schedule may be busy, but I'm sure yours all are too. And for me, this is lovely middle of the day timing, whereas for many of you, it's both early in the morning and late at night. So thank you for making the time to come and listen, and I hope we'll make it worth your while.
Thank you very much, Jolene. And I guess for today's topic, it's really about health equity among older adults. So this can of course encompass various topics, various issues, with health equity spanning just a wide umbrella of various components. So with that, to help set the stage a little bit, could you walk us through what we really mean when we say health equity?
Yeah, okay. If you don't mind, I'm going to start by prefacing. I probably should have mentioned is why in the world is an economist involved in any of this in the first place. And one of the reasons I got involved is because I grew up in one of the most unequal countries in the world, South Africa. And that overarching inequality was really underpinned by a health inequality, which I later understood to be an inequity. And we academics love a bit of semantics. So the difference between an inequality and an inequity is an inequality is just a mathematical lack of equalness. And an inequity implies that there is something unjust or unfair about that lack of equalness. And so actually, the reason I got involved was to try to tackle the medical poverty sources of wider and persistent inequalities and inequities in the society around me. And that then grew into a wider a wider program of work. So really, this inequalities and equity thing is the foundation stone for a lot of the work that we do at UCL and a lot of the work we do in my team. And really what we're talking about when we're talking about health inequity is it's an unjust or unfair imbalance in the health outcomes or potential to achieve health outcomes in a particular group. And we're really seeing this in older populations as populations age around the world.
Yeah, well, thank you very much. I know we had a brief chat, I think it was about 2 weeks ago, and when you mentioned something that really captured my attention when we were talking about this topic, and that was the social determinants of inequity. I thought that was very interesting. We often hear about the social determinants of health, but not as much as much about inequity. So can you unpack this for us a little bit? What does the social determinants of inequity mean? How does it tie with the broader topic of health equity among older adults specifically?
Yes, of course. I think it may be worth putting it into context. So we normally think about the determinants of healthy aging as economic determinants. So can you afford to age healthily? The social infrastructure around you. Do you have contact with friends? Do you have contact across generations? Um, the physical environment, how mobile, how are you able to navigate your environment? Is it a safe environment? And then that fifth one, the social determinants of your health, which are a combination of those, but not in the moment. A lot of that goes right through back into childhood, where people experience very different um, starting foundations. So you might have different diets, you might have different housing structures, exposures to pathogens, and then different working exposures as you move through life, different risks within your working environment. So we do need to think of healthy aging as a cumulative effect of the risks experienced across life. And it's not just down to your physical biome or your genetics. Those can be absolutely affected by the risk factors in your social, socioeconomic, and physical environment.
Yeah, no, thank you for that. And you mentioned, I like that healthy aging as a cumulative effective of the risks across the life. That's quite powerful. Can you perhaps expand on that a little bit more? So what are some of these risks that you're talking about?
Well, if you don't mind, I'm going to use malnutrition as one of those fascinating ones because so again, for the benefits of having started my career actually working in early child development, child survival, we were dealing with stunting, severe acute malnutrition, children who did not, in the first 1,000 days and in their first 5 years, have enough to eat. What we're now seeing as those children reach late life is those children who are most undernourished in the first 5 years will end up being at greater risk of diabetes, ischemic heart disease, and obesity in later life. And we've learned a lot about how that human organism becomes sort of super processor of calories when there aren't enough around, and that programming, amongst other factors, of course, can remain once your diet then normalizes. And so a diet that wouldn't make an older person sick who had had a sufficient diet in early childhood may well make them sick if they did not have a sufficient diet in childhood. So that's just one way that the risk factors in your very early life can predict or can create the groundwork for higher risk factors in later life. Um, and that translates across air quality, indoor home exposure. Did you have a warm, safe home? What was the indoor air quality like? Was it damp? Did you develop any cardiac or pulmonary risks as a result of that? So I mean, there are many that I could pick, but I hope those one and a half at least expand your understanding a little bit.
Yeah, I think really what's coming across to me at least is that aging isn't just about, a specific age. It's across the life course. You need to think about these various aspects from childhood into older age as well. So that's kind of some of the key takeaways from me from that. And thank you very much for outlining that. Now, we are also living in a time with just a lot of different and rapid changes occurring, whether that's social, whether that's environmental, technological. So my next question to you really takes on that perspective to tie the changing environments we live in and health equity. So what I'm really asking here is, in the rapidly changing society such as ours, how does urbanization, how does climate change, and just the changing nature of societies altogether impact health equity in older populations?
Oh, it's absolutely fascinating. We're going through such a rapid period of change in lots of ways. Before I answer, I'm going to say, Cynthia, yes, I'm going to be in Cape Town, and we have 5 different panels going on that I'm participating in. So I look forward to a chance to speak with you there. Right, how is our changing environment? Let's start with the urbanization. So in low and middle income countries, which is actually where the majority of the aging population is currently based, we're experiencing rapid urbanization, often unplanned rapid urbanization, so growth in informal settlements, often a lack of the infrastructure that you would want to accompany urbanization. So there may not be a sufficient supply of healthcare or roads or security even, and safety or lighting. So what you might and that can affect older people in 2 different ways. One is if they themselves are moving to urban areas, the environment in which they're living may not suit their needs as an older person. So that's the first. The second is if they don't move to urban areas, many of the social strands that would have supported them in rural areas historically, provided them with food, support, care, social interaction, that network moves to the city and leaves an isolated older population in rural areas. So you have 2 sources of risk within that rapidly urbanizing trend. The other rather fascinating trend is the increase, and it's happening much more in sort of upper middle and upper income countries, is technology adoption. And that can have both positive opportunities for aging, but also negative. So we're finding older workers in many cases, and this is through their work with the Institute for the Future of Work and actually the UK government, older workers feeling closed out of workplaces or alienated by newer ways of doing things because they aren't taken along on a training journey. They aren't always integrated into the way that new technologies are being used. It can also, however, offer you a way of keeping in touch socially and bridging some of that urban-rural distance if you have a way of staying in touch with your family and communicating better. So there are opportunities, but there are also risks to workplace participation, which is a trend we're also seeing in the environment. So as populations are aging, those with sufficiently sizable formal workplaces or formal employment sectors are encouraging people to stay and work longer. And that too has positive and negative gains. So, there can be positive gains to continuing to earn, to continuing to have that social contact and that structure and that stimulation, but not necessarily if you're in a very physical job. That may be tiring, that may be less possible, may even be higher risk if there's a risk that you actually can't function within that job. So a lot of structures changing. I'm going to say urbanization, communications and technology, and the changing nature of work and delayed employment are just 3 that are worth touching on here.
Yeah, no, thank you. It's funny you say that because our last week's speaker also touched on kind of technology and the different opportunities, but also risks that are involved. But hearing your thoughts now, it sparked kind of a related question. So with health equity, there are various overlaps with other areas like housing, social protection, digital access, and so forth that you just mentioned. How important is it to look beyond just healthcare as well when designing equitable kind of like systems for aging?
I think it's absolutely critical. Part of it's not a trend, it has always been, we have historically viewed health systems as healthcare, right? So, to a disproportionate extent, we've seen it as curative care. We want to treat disease, we want to treat illness. That's valuable. I don't want to, dismiss the value that that agenda has created. We do want cures for curable diseases. We do want illness to be treated. But what we need to develop alongside of that, especially as populations age, is a sense of person-centered care, preventive care, holistic care that's not necessarily happening within institutions. And that brings us back a little bit to the social determinants of health. So a lot of the diseases we might think of as common illnesses in older age are prevented by non-health interventions. They're prevented by good food. They're prevented by good housing. They're prevented by good air. So we really do have to think about public health as a life course trajectory, as a life course mission, and public health isn't a single sector objective. And really, until we do that, persistent inequity will follow, because the inequities, that the unjust imbalances in the outcomes, are being driven in part by differences in access to healthcare and drugs and medications and diagnostics, but to a large extent by the wider differences in those social foundations: food, housing, water, air, really basic. And we aren't getting those right in a lot of contexts.
And I think there's the structural kind of barriers and elements to that. But then would you say education and awareness is another issue, or not as much?
It is, right? And we've absolutely found in almost every sector of health in which I've worked that education brings health benefits, right? So because it helps you to take control of your behaviors, to maximize the returns to what you eat, how you move, what you engage with, it's empowering. Education gives you power over your health trajectory. But I do feel we need to be careful, and I actually want to note Shmuel's question in the chat about what should wider institutions do about this. That individuals can be responsible for individual health up to a point, but we will perpetuate the widest inequalities and inequities if we expect individuals to do everything for themselves. This is a collective action agenda. And I say that based on evidence, because those countries, and I'm going to tactfully not name them, which are the most individualist in their approach to health, welfare, and wealth, are the ones where we have some of the widest health inequalities, and amongst disadvantaged groups, some of the lowest health outcomes. And the country I have in mind is one of the richest in the world. So this is not about an absolute level of resourcing. This is about an intention, an approach, a philosophy. So the education is great, but we've got to place the individual and the individual's responsibility within an enabling institutional and social structure that is not putting all the onus and responsibility on an individual. We economists are obsessed with risk pooling. And that's really what we want to do across the life course, right? Because there'll be times when we are strong and times when we are weak. And when we are weak, we want to be held up by the strong. And when we're strong, we are happy to hold up the weak. And that needs to ebb and flow across a life course. That needs, golly, I'm really am showing my politics here, but that really needs to ebb and flow as well across a wealth course, as we enter job markets, as we earn more, as we fall out and earn less. So I think there's important consideration of the individual responsibility, the social, and then the wider institutional responsibility.
Yeah, no, thank you. And thank you for kind of pointing to Shmuel's comments. Shmuel is a continued Global Cafe attendee, and I was wondering if you wanted to unpack a little bit more specific to his question about the role of like WHO and UN. I know you touched on it, but is there anything additional that you want to add to that?
So I was very excited to hear. I should mention that I'm a trustee of Age International, based here in the UK, and that charity, which I've only just joined, so I can take absolutely no credit for any of this. That charity has been very actively campaigning for a UN convention on the rights of older people, and that is in the process of being approved. I think that's something we want to get embedded. We need something about what are the rights of people as they age, the rights of populations or groups of older people. And I think really I'd like to turn to one of the other comments. I think it's Stanley who talks about dignity, and one of those rights we might want to consider is the right to a dignified life, and in doing that will force us to think about what that means. What do we mean by dignity? What do we believe is a fundamental human right that we want to embed within that? So there's something about a rights-based approach that those UN institutions can support. UN institutions will only ever set the infrastructure and the enabling environment and the nudges for nation states and national governments to act, and they too will really only set the nudges for communities to act. That is important, and I'm going to say in the current environment in which many of those UN institutions are being undermined and threatened, I really should take the opportunity to emphasize their importance in setting out through multilateral bargaining, and I don't mean bargaining in a sort of trading way, I mean bargaining in an international consensus building way, that international consensus about what we want to achieve, what do we value in terms of equal opportunities to age well.
No, thank you. Thank you very much. And thank you, Shmuel, for your question. I know, Janine Sharnley, you've put a comment in the chat as well. I know you're also coming to Cape Town in September. Would you like to unmute to kind of discuss your comment and if there's any questions for Jolene?
Well, what I've been thinking about a lot lately is with older people needing to move more into, continuing to work later into their older life, is that they've drawn away from those traditional roles that they've had, where it's child rearing, sharing their wisdom to the next generation, doing volunteering roles in their communities and being that real core of the community. And that's something that I'm kind of concerned with. It's like, well, what does that look like going forward, where older people are needing to work longer into their life, not being able to do those traditional roles, and what's actually being looked at in that. I'm not looking at anything, and it's only kind of something that's kind of popped onto my radar. But is there anything that's being looked at into that, and what do we have any concerns around this, or what's happening into the future in this role?
Janine, I think that's a really excellent question, partly because the other big global trend is to move responsibilities for a lot of those functions away from governments as national purses are being stretched and pressured. They're moving into big society. I mean, the UK had this whole push of basically do it for yourself communities, right? We won't provide care, early childcare, you do it. We won't provide food banks. Communities are doing it here in the UK, and disproportionately older people, amongst others, do engage in those volunteering roles. So as governments push those functions onto societies need to think about who can take on those functions. So conceptually, this is a big problem. There's very little evidence, though, to talk about what this means. Now, perhaps it all equals out, because actually what we're talking about is aging in an increasingly, in a context of increasing longevity. So perhaps that retirement, the number of retirement years is equal. It just happens later. And the number of...
Well, what we've seen is that the number of healthy life left kind of like while we're aging, but our years of healthy living hasn't increased at all. Like it's kind
hasn't
of stayed
necessarily
the same.
increased.
Yes,
absolutely. So. And that because of some key challenges. So things like dementia, which begin at much the same age that it always has. And so we haven't pushed that any later. And so we don't get any gains from that. No, Janine, why I wanted to segue into your question immediately is we need so much more research. I mean, Roxana has been very generous in describing me as an expert, but before I even joined, I said, I don't feel super comfortable with that. I'm not sure we have, sort of in the academic sense, real aging experts, partly because we have invested so little in the research, the evidence, the monitoring, the evaluation of this. And so
I'm so glad you said that, because I feel the same. I'm like, I feel like I have more questions than I have answers for,
yes,
which is
where are these
which is
data?
good.
Why do we not have these data? Why are they not on a? So that is another role, by the way, for global institutions. I know the WHO is doing some work on this. There is some nascent work, but because I think historically the aging problem, and I we all love an air quote, but was seen as a luxury, right? It was a high income country issue, and it wasn't actually a problem. It was a nice to have, and how lucky that you've arrived there, and so it wasn't seen as something that we needed to resolve outside of economics. So within economics, we've been obsessed with the dependency ratios for a long time because we've seen
Yeah,
aging increase, we've
how do you
seen birth
fund?
rates
Yeah, we need
fall.
that tax. Yeah, we need
That's
that
it.
tax
So
revenue to keep
exactly.
the
So the
countries
public
going.
finance, that's it. The public finance economists have been going, wake up, guys, we've got a major problem. But the public health agenda hasn't been there. It's been on, I mean, I've been with it, right? So I'm just as guilty. I've been on child survival. I've been on early life thriving. I've been thinking, look, we haven't finished that enormous body of work. But even in those countries, South Africa, India, China, where we haven't completed the child survival challenge, we are simultaneously having to deal with the aging challenge and opportunity, but we aren't thinking about how to maximize those opportunities. And really, I think the public health community, and I'm saying this as an economist, the public health community needs to shout much more loudly, because the economists are dominating this conversation with a heck, how are we going to pay for it all? And in a way, I think we need to really pause and think a little bit. I mean, it's great that we've talked about, Stanley's comments about healthcare, welfare, and dignity is pointing to the idea that we can't keep leaving people in hospitals for issues that don't require hospitalization. We have to think about what are the particular challenges of growing old in place with dignity. How can we support that? This doesn't require a lot more specialist doctors necessary. This requires a rethink of the integration between health and social care. And in addition, what is the role of older people? They're framed as dependents in the economic argument. Are they dependents? And this is also, I'm sorry, I'm gonna go off on a bit of a rant. Roxana, reel me in when you need to. But this is also a gendered issue, right? So for years, we have had women in unpaid roles that don't count. And Janine, the roles you've been describing are these feminized roles that don't count economically, right? Because they aren't bringing in tax dividends and they aren't bringing in income. Hi, do we need to rethink some of this?
No, thank you. Jolene, thank you, Janine, so much for your questions and your insights. And I encourage folks to please provide your questions in the chat. I think related to this, Cynthia, you posed a question in the chat, so I might ask you to speak on that a little bit more.
Well, thank you. It really dovetails on what you just actually mentioned. But I want to first say it's so enlightening to hear someone present with such a holistic perspective. But my real question, what I posted, was really about how do you think we can overcome the gendered ageism issue, which you just articulated before? Really looking at, I've really been giving that a lot of thought, and I'd love for your perspective. How do we address that? And it isn't a short-term solution, I think.
Yeah.
But
Oh, Cynthia, I wish I had the solutions. And this is partly, so research is not just about tracking the problem. Research is about investigating the solutions and finding out what works. And we aren't doing that yet. But what I think what we need to do, and I thank you very much for describing my perspective as holistic. I sometimes think I'm a sort of Jill of all trades and master of none, but I think what we've got, some of this is rooted in gendered inequality. So gendered aging and the inequality of gendered aging is actually rooted in the inequity, in gender inequity across the life course. So again, we need to really start at the beginning. And some countries are doing slightly better at that. There are some of the Scandinavian countries that start with some basics like equal family leave. You know, it's such a fundamental policy that basically says childcare, family care has a value, and men and women should share it equally. And I know Sweden has been toying unsuccessfully with trying to legislate for the equal sharing of domestic roles within the household. Now, how do you legislate for what happens behind closed doors? I don't know. That's why they haven't succeeded. But at least the policy argument, the policy discussion is telling you that that society is signaling the need to not only say this is how we want things, but we're prepared to enforce it. You know, and that mindset shift's got to come from a couple of places. So I think gendered ageism is partly about gender inequality across the life course, but there's something else. And I say this as a woman of a certain age, right? There is something else about gendered ageism, which is age specific as well as gender specific. It isn't happening in every culture, Cynthia. So I wonder if actually we should be looking cross-culturally and at different ethnic groups for lessons about how we can prevent this. And we really haven't shifted very much. You know, we had a dinner conversation last night in my home about aging backwards in Hollywood, and I was horrified. So I'm not sure we're making much progress, but I think we should look to what other cultures are doing that is addressing this. We should be thinking with a social anthropology lens, which I'm going to say is one of my weaker lenses, at what we can do to change the realization of philosophies within cultures, because that's really what this is, right? We as a society do not value older women as much as we might value the wisdom of older men. And I don't know how we get around that. I wish I had the answer.
We'll find the solution in Cape Town, I'm sure.
We will. Many cups of South African tea later. 5 Roses tea.
There we go. And thank you so much, Cynthia, for your question. I know Home Shrestha has a question in the chat. Home, if you're able to unmute, please pose your question. If not, I'm happy to read it out loud as well. So, oh, there we are.
Sorry. Hi, good morning, everyone.
Good morning.
Yeah, congratulations, Professor Jolene, for your excellent presentations. So I'm a bit concerned about that because I'm a student for the health policy and equity, and my project is focused on the culturally safe dementia care for indigenous older adults living in dementia in Ontario, maybe focus on in the central Toronto as well. So I'm so curious that, you know, about what are what could be, you know, the real challenge or barriers, you know, maybe to access or to, you know, to provide, you know, or to ensure the health equity for older adults to improve the focus on improve their quality of life, their, you know, what is called aging health, as well as, you know, their holistic wellness. Specifically, if you focus on the indigenous older adults, the living with dementia. So I'm not talking about the Canada, US, but I really want to know, you know, the whole global. So globally, how indigenous peoples living with dementia, you know, have, you know, the support or whatever, you know, for, you know, as a part of the, you know, the health equity and policy. How does it work? And what are the challenges and barriers?
Golly, thank you. It's a really great and broad and important question. I suspect that there are people on this call who are more expert in this particular area with this particular population than I am. So forgive me if I misspeak, and please, if you are an expert on this area, come in and tell me where I'm doing your work an injustice. I'm going to have a go at this a little bit. Indigenous peoples around the world are actually a very diverse set of peoples. So I'm going to start by saying that. And what I will do to give you some clarity in my response is to perhaps think about those Indigenous peoples who are minority groups within their countries rather than majority groups, which in a country like South Africa, the Indigenous peoples are the majority group. So let's think about the minoritization of Indigenous groups within many countries around the world and what that means. And one of the key barriers or key issues around achieving equity in access to high quality care and support in that environment is actually, well, I'm going to say there's two. One is from the systems perspective. So often those systems for support are not located where those Indigenous populations are located. So you actually have a kind of physical geographic barrier. You might have really excellent care centres or in-institution care or even support for at-home care that exists in urban and suburban centres where many of the Indigenous minority groups do not live in those places. And so there is a physical problem in accessing those. The other issue in which will challenge the equity of access to that equitable care is, to a greater or lesser extent, and this varies across contexts, so I caveat this by saying this, is a distrust of institutions. And that distrust is a learned distrust, learned the hard way by institutions which historically did not necessarily have Indigenous people's interests at heart. And I know that we've got Australians on this call who could speak much more knowledgeably to some of the issues that I'm mentioning. And I know too that we have Canadians on the call who may well be able to do the same. So just flagging that there may be a self-imposed barrier to accessing equitable or effective care by those who do not trust the systems providing that care. And I think those two sets of challenges intersect in a particularly heightened way. So, there's institutional distrust across large swathes of many societies. It's not specific to Indigenous groups. The sort of anti-vaxxing movement is the poster child for institutional distrust. So is the populist rise of the far right. So it's a phenomenon that we're seeing elsewhere. But in these Indigenous groups, it's particularly heightened because it's the product of a long history of poor relations with institutions. Those Indigenous groups are not responsible for those poor relations. And then there's this geographic issue that overpins it. I hope that gives some clarity and some food for thought.
Yeah, thank you so much, Professor. But what about the funding? Is there any, the barriers, challenge for funding for the program?
Yes, and again, that differs from country to country. So in some contexts, there's a deliberate intention for reparations. There's a deliberate intention to prioritize funding for certain groups. Jolene, you're quite right. That history is not that long ago, and in many cases, it isn't history; it's current day. So some countries, some contexts, there's an intention to try to make right. In other contexts, there might be some rhetoric around that, but the funding isn't there. So there could be good talk, less action. And in other contexts, there is neither the intention to put the funding. So again, you're quite right, Hom. There is not always a dedicated or specific funding stream that is sensitive to the other intersectional barriers to care. And so all of this creates a sort of perfect storm of risk that drives the persistent inequities in care for dementia, but also for other things in older populations particularly, and in Indigenous groups, minoritized Indigenous groups particularly.
Thank you. And thank you so much for your question. And thank you very much to everyone for your comments in the chat. I know there's a number from Janine. So thank you. I know, Brendan, you mentioned a comment previously about prevention being quite key as well. So thank you. I think throughout the discussion, Jolene, you've really provided a lot of food for thought from our end, but that brings us really to the roles of policies as well. So where do policies fit into all of this? And how can global policies, and I know you've touched on this, but I guess in more detail, how can they help address future threats and lay just really the foundation for sustained health equity practices for older adults across nations, really?
Yeah. And again, I'm going to horrify the political scientists who are on this call by grossly oversimplifying the role of policy. So apologies in advance. I'm going to say the role of policies here is twofold. Firstly, the role of policies is in framing and flagging what we value and what we do not value as a society. And that society could be a local community, that policy. So because in the UK we have, I'm part of a borough in London, which is a subgroup that contains more than 1 million people, but it's a borough within the London Greater Authority, within England, within the United Kingdom. So, but at whatever level that policy is set, it has the intention of flagging what we value collectively and what we do not value collectively. That is why it is written as a policy and voted on and accepted or not accepted as a policy. So that's one of it. It's a kind of framing, it's a stick in the sand. The other thing that policy aims to do is fix things, right? So it policy prioritizes what we collectively believe is most important and then should aim to address or redress the issues that are captured within that aim. I'm going to say we're probably ready for the stick in the sand section of policy on equitable aging. Because of the lack of evidence and testing, I'm going to say policy is immature on acting for healthy aging. And that may be why some of you will come away from this call thinking, golly, Jolene talked about a lot of stuff, but we don't actually have any idea of what we should be doing next. Because we know lots of things we should probably be doing. We should be looking at that gender equity. We should be looking at, physical environments, social environments, health systems as integrated care. I can give you some buckets of what policy should be doing. I can give you some steers of what policy should be doing within those buckets. But the context specificity, what's going to work within an individual community that has a standing environment or a kind of baseline set of service provision, that needs tailoring. And for that, we actually do need much more. We do need some monitoring and we do need some high level thinking. We always do, but quite a lot of what we need is realist research, practical learning by doing work. And I'm going to put that out to the NGOs and the policymakers. Academics like me work very closely with policymakers in almost every other field. But because aging isn't owned by any particular it's not health, it's not welfare, it's not housing. It doesn't have an umbrella with a minister who's responsible for those things. The entry point for the engagement of evidence, academia, policy and action, that's a bit more diffuse. And I think maybe we should start by having champions for healthy aging in all of our contexts at the government level so that they are responsible. They set some targets. They say, this is what we're going to aim to achieve now. And they're held responsible for them. I don't know who I'm holding responsible for things here.
Oh, that was a lot, but thank you.
Sorry. Negative.
I think it's great. So thank you so much. I guess my question is, do you know of any countries or regions that are slowly going towards that, or any best practices that perhaps we can learn from?
I think there are people on this call who could probably tell us if it's happening in their regions. I don't know of any offhand, but that doesn't mean that it's not happening. I think what's happening is aging is being seen as a cross-cutting issue, which it is. The risk with cross-cutting issues, and I had this with early child development, by the way. In early child development, it's not health, it's not welfare, it's not nutrition, it's not climate, it's all of those things. And healthy, equitable aging is the same. It's all of those things. But then you risk falling between stools. So it's fine that it's cross-cutting, but we need to create ownership at an accountable level. And I don't know of anywhere that's got that accountability built into their structures. And I hope that others on this call may know of cases where that's happening so that we can learn from that experience.
Yeah, no, thank you. And I know we are slowly coming closer to the end of the session. So I do want to talk a little bit more. I want to ask a crystal ball type of question for you.
Oh, okay.
So as a crystal ball question, let's discuss how we can move forward from here. You mentioned a lot in the policy piece right now. How can we all also just advocate for better health equity as part of policies, for example, but just as well as part of the overall narrative of healthy aging altogether? I think we all have roles we can play, and what do you suggest we should do as first steps?
Okay, so please all lobby your respective governments to support the UN Convention on the Rights of Aging Populations. That's coming up. Your countries will all want to vote, will all be asked to vote on that. Please have them vote for it. So that's a first. Let's all say that this is an important issue that we want dealt with dignity and with a holistic approach. So that's first. Secondly, identify who your agents for change are in your environment. So who are the policymakers or policy leads within your context for whom this is important? Who are your champions? Now, they won't be obvious because there isn't a ministry for aging, certainly in the United Kingdom, and maybe there should be, but they are champions within government who will do that. And in the United Kingdom, we've got a process called all-party parliamentary groups. So it basically means this isn't a partisan thing. We've got the structure for pulling together some thinking. And so find your champions and speak to them about how we create more accountability within local and national governments. And then what we need to do is we need to think about how we frame this as an opportunity we really need to grasp. Because aging is a great thing, our aging populations. We have it because we have enabled our populations to live longer. This is to be celebrated. We have that experience retained within our communities. And I think we need to start to really focus on maximizing the gains of that and not just seeing this as an economic problem to be solved by changing ratios.
Yeah, no, thank you. And how about the role of like intergenerational collaboration as part of this?
Oh, so in fields in which I work, this is called allyship. Intergenerational work. We live in intergenerational societies. You know, I am a parent to a child. I am a daughter to a mother. I am a grandparent to I'm a grandchild to a grandparent. And those links are the fabric of our social networks. But we need allyship. We need young people to say we care about older people. At the risk of really upsetting people, in the United Kingdom, we had a vote on our membership of the European Union that split down age lines. And I'm just using I'm just using it as an example of where we possibly could have achieved better allyship, better desire to protect each other. Why did we split along these age lines? Because we put people into competing camps. We've pitted people as a society against one another. I don't think that's the fault of the young or the fault of the old. I think it's the responsibility of our social fabric to show what we bring to each other across generations and not what we cost each other across generations. And at the moment, a lot of the discourse is around what we cost each other.
Thank you. A lot of powerful comments and just discussions today, so thank you so much. We are coming close to the hour, and I would love to hear some of your key takeaways for us all from today's discussion, Jolene. But to allow some time for you to just gather your thoughts, I know a lot of topics were raised. We are just going to introduce next week's topic and speaker. So next week, we have the opportunity to listen to Miss Cindy Morris as well as Miss Grace, and apologies for the pronunciation, Audra Swiss, for a life course approach supporting women through age and change. A very great topic, and we look forward to seeing everyone in the Global Cafe next week. But back to you, Jolene. In a few sentences, may I ask you for your key takeaways today to share with us all?
Okay, great. I'm gonna give you 3 if that's okay. Firstly, I'm going to say that healthy aging is currently not equitable around the world. There is an unjust and unfair distribution of the of ill health across our older populations globally. And the second point I want to say is that that's not inevitable. That is not just because it will always happen. We have agency in changing that. And the third point I want to make is that we need both action to change those things we can change, to get more equitable distribution of health gains across the life course. And that action needs to be owned so that we can hold the actors accountable and also give them credit. You know, I live in a world where it's all about critique. Let's give credit for progress where it's achieved. Let's learn from the successes that we see. Let's not repeat the mistakes that we make. So let's have good monitoring and evaluation of what we're doing. And let's make this a priority for all of our countries going forwards. Janine has mentioned that the Convention on Rights is not currently enforceable in courts. And we need to move that forwards. We need to say, this is our value set, and we are prepared to enforce that value set, both with action and with law. But we will need to do less legal enforcement if we actually have a social buy-in to this contract across generations that we value healthy aging equitably across the world.
Thank you. Thank you so much, Jolene. Before we sign off, I also just again want to thank everyone for another great week of our Global Cafe sessions. A special and grateful thank you to Professor Jolene Skordis for joining us and the incredible people just joining the Global Cafes with your insights and questions. Janine, Stanley, Brenlin, and everyone else, just a big thank you. And finally, thank you to the people who work at the IFA who help support not only this cafe, but a lot of other ones. So thank you very much, Berenice, as well. I hope we are able to see everyone next Friday and wishing everyone a great weekend ahead as well.
And
So
thank you for your excellent convening of this, Roxana. And thanks for all your questions and comments. It's been an absolute pleasure. Thank you.
Thank you. All right, everyone, take care.